Good afternoon. Good afternoon for this session. My name is Gudrun Schleiermacher from Curie Institute in Paris, France, and it's my pleasure and privilege to chair this session in this afternoon. First of all, I would like to thank the organizers for inviting me to participate in this really inspiring meeting and symposium. And so this session now is about measuring response to treatment. We've heard a lot during this day about what neuroblastoma is, or what it is not, all the different facets of this disease, as well as the many discussions about treatment in the front line and then in the relapse setting. But many other questions arise from this. How can we, for a given tumor in a given patient, select the best treatment? How can we be informed about how to choose this treatment? And also, how can we evaluate the response, and how can we make use of novel technologies for evaluation of the treatment and use this to inform further steps. So in this session we have three fantastic speakers, Professor Meredith Irwin from the Hospital for Sick Children in Toronto, Professor Kelly Goldsmith, who will be joining us from afar from Emory University School of Medicine in Atlanta, and then Professor Lieve Tytgat from PMC and Princess Maxima Center in Utrecht in Holland. And as in the previous sessions, after the three presentations, we will have our panel discussion where Sally George and Fabio Benidio will also be joining. So with this, I would like to introduce our first speaker, Meredith Irwin, who will speak to us about the biology of neuroblastoma. Thank you.
Thank you. I also want to thank the organizing committee for inviting me. It's been a real privilege to be here for the last couple of days and hear this great conversations today. So hopefully this talk now will tie together a lot of what we have been speaking about. Okay. So I was asked to introduce myself. So very briefly, I like to do things with pictures. I'm from Toronto, which currently is part of the Commonwealth and hopefully will remain part of the Commonwealth in Canada at Sick Kids, where I'm a clinician scientist, like many of my colleagues who will be joining me on the stage later. I'm also an active collaborator with my COG and INRG colleagues, and I'm also a parent of two now adult children and a small puppy, who many in the audience have met. So these were some of my overall objectives. I'd like to provide, we've already talked about this, but a bit of a framework for how we think about precision oncology in neuroblastoma, understanding how biology has really influenced and will continue to influence risk classification. I'll speak about where we are with biomarker testing and hopefully give you some glimpses into the future. So when did this start? It was over 50 years ago, and I got this slide from Peter Adamson, who used to be the head of the COG, Children's Oncology Group, and this is from Audrey Evans' index cards. This is before electronic health records, and Audrey Evans, as many of you know, we think of as really one of the pioneers of neuroblastoma, or the mother of neuroblastoma to many of us. And she used to notice that some of her patients were more like some others of her patients, and some were quite different. And so apparently, what Peter has told me is she would put piles of index cards together that were like patients. And from that, she developed what I think we would all call the first staging system, the Evans staging system, and which was really our first approach to precision neuroblastoma or risk classification. And I'm just quoting that line from her abstract that says, stages can be used to estimate the prognosis and can be used to determine treatment efficacy by comparing comparable groups, which is what we've all been doing for the last 5 decades, I think. I haven't been working that long. But, and I think Ro Bagatelle spoke this morning about the spectrum of clinical heterogeneity of neuroblastoma, and this is just another way of showing the very same thing from very low-risk patients shown on the left who often have localized or young babies whose tumors may just disappear without much treatment. And then in the middle are the patients who maybe need a little bit of treatment and or can have a surgical resection, whereas on the right are the patients we're really speaking about the most today, the 50% or so with highly often resistant, but not always, disease. And so how did we get to a sort of, and how will we get farther into a more detailed or optimized precision approach? And you'll hear more about this through my talk and the next two speakers, but obviously biology is a big part of it. So when we all started, Ro and I have a lot of similar type slides. It wasn't planned at all. Neuroblastoma was thought of as looking the same for all patients. And then as you've heard about, we came up with using clinical factors like age and stage and biomarkers that we've been using for a long time, like MIC-N, histology, the copy numbers of chromosomes, and we're able to classify patients really at most of our centers in fairly similar ways into low, intermediate, and high-risk groups. And as we've talked about, by doing so, we're able to, I'll say bucket patients into different outcome groups and then follow those patients and assign therapy across all of our different groups similarly for all patients so we can then compare them. And Ro also put up some of these slides, and I just want to point out that both in the INRG, which is the large international group that many of us collaborate with, as well as in the Children's Oncology Group more recently, we updated our risk classification. And all of these schemas are really not just to guide us at our neuroblastoma expert centers, but really worldwide so that we can all have similar approaches, both to how we put patients onto trials and make eligibility criteria, but also how we treat the many patients who, for a variety of reasons, can't go onto trials. But really the goal, we've talked in some of the sessions about people's vision. I think my vision, like many of you, is to use all of the biology, the biomarkers, the data, maybe AI, put it all together and not just have three groups, but really figure out how we can be more precise in how we think about patients. I'll speak a lot about this at diagnosis, and my colleagues will speak more about how we think about it also at relapse. But where are we now? So let's go back to 2025 and not the future. So what are the biomarkers that we use now? And I'll just highlight a few that you know a lot about, but just to also talk about the lessons we've learned so far, which we now take for granted, but are really how we'll hopefully also move forward. So to do this, I'm going to quickly just go through a few concepts. So I think you all know we like to collect a lot of samples, both because we know some things about what we should look for at the beginning at diagnosis, but we're trying to learn more and more about what we could learn along the route, along all of this treatment to figure out if it's still working, or as Nick said earlier, are we destined to sort of not have the right therapy for the right patient, and can some of these tubes or samples teach us something about that? But I'm going to focus on diagnosis and review a concept that's pretty important to what we're talking about, and one of the families actually brought up earlier. But first, just to remind everyone, I think everyone in the room knows this, but at diagnosis, as you heard this morning, we need tissue. Tissue is the issue. We need a good amount of tissue for now until we have better ways of looking for some of these biomarkers. And we need that tissue, and so surgeons and often interventional radiologists get that for us from our patients. And we hope we have enough of that. We also take bone marrow samples, and increasingly we're doing more things from the blood of our patients to not just look at genes, which you'll hear more about, but also their immune system, because we know that may be very important in figuring out who's going to respond later to those immune therapies. But here's the concept I quickly wanted to review, and we've alluded to this a few times. So I think historically we thought maybe all the tumor cells were pink, and sort of shared the same personality or the same genes. But we now know that even at diagnosis, there are some differences in all of the different neuroblastoma cells. Sometimes we can see that under the microscope, but often we can't. But what we do know is as we treat the neuroblastoma, what we think happens when we treat, especially with single drugs, but even with multimodality therapies, is if the neuroblastoma comes back, it may come back with a slightly different personality or with growth of some of the older clones that get more popular or larger percent of the tumor cells, or a new one like the purple cell. And importantly, we also know that even within one patient, there may be differences in a primary tumor site, for example, and a metastasis. And Kelly Goldsmith will speak more about how we look at response and how it may not always be the same. Maybe that's the biology. And I just want to also point out that there are immune cells, as we've heard about in the tumor. So when we do get a biopsy from our surgical or radiology colleagues, we are just getting part of the sample. And that's one reason, as one of the questions asked earlier, we do often recommend a repeat biopsy at the time of relapse, since the colors of the cells and their various profiles may change. And then, of course, from that, the pathologist and all of the various labs that do our biomarker testing get samples and do that testing. And I want to highlight how important it is when families agree to extra sample being used for research, how important that is for all of the work that has made discoveries up until now and will be making discoveries in the future to make models for all of the things that we want to try to do in the laboratory to be smarter about the drugs that we want to recommend for your children. And hopefully, as Lieve will tell us later, liquid biopsies will relieve us of all of the need to do many of these biopsies. And importantly, we believe the liquid biopsy may give us a sample of all of these cells, even if the surgical biopsy would maybe miss a few. So biomarkers. I'm going to have a couple of slides on what we're using now and what I hope we'll be using soon. So you've heard about MICN. I know it seems like that's so yesterday, and like, why are we talking about MICN? But really, I think it's still the most powerful independent marker. And on the right, you can see about 15 years of our children's oncology group patients, agnostic to stage, age, et cetera. And it is, you can see, hopefully, one of the most powerful markers. And almost any patient, regardless of their age or stage, is high risk. But I do want to point out that when I started in the late-ish 1990s, we treated all metastatic patients the same. They all went on to high-dose therapy. However, we learned right when I was in training that it appeared that MICN could tell us about patients that maybe didn't need transplant, that idea of reducing therapy. So towards the end of my fellowship, we realized we didn't need to transplant all stage M patients. We take that for granted now, but I remember some of my own fellow patients getting transplanted who today we would say didn't need that treatment, for example. So that's how we hope to move the field forward with those sort of changes in therapy, not just to add on, but to reduce. So there's lots of tests for MICN. FISH is the sort of standard one that Rose showed that I show on the right that can be done within a couple of days at most of our centers, but all of the fancy new genome tests can also help us figure out MICN. Another very important prognostic factor, which Gudrun Schleiermacher, who is our moderator, and others really pioneered, was sort of the copies of chromosomes that are in the tumor cell, and if we're missing little pieces of some, or gained little pieces versus if we gain large pieces or lose large pieces, that actually tells us something. So segmental chromosome aberrations, the top one, SCA, is when you lose a tiny piece, not that tiny, but a small piece, as shown on the right for 11q loss. Numerical chromosome aberrations is essentially when you gain or lose the whole thing or close to the whole thing, and that seems to be more favorable. And there are a lot of ways to find out this information, and most of us are trying to do this to, again, better discriminate our patients. And this is just the curve, and the arrow is there to show you that the SCAs, those tiny little gains or losses, are much worse than not having them at all. So it's a pretty important marker, probably not as much if you have MICN, but without MICN, it may help us further distinguish. So where do we want to go? And again, in the last session, I keep saying Nick sort of was a perfect introduction. He mentioned a few of these things. We need better biomarkers for our high-risk patients because they're not all the same. Currently, we will say to all of you, we get all this tissue, but we don't really know how to tell you if a patient is over 18 months and stage M, who's going to respond and who's not. Importantly, if there was a biomarker, we could maybe change your therapy, not necessarily add more, but maybe take a detour and do a different type of treatment. We also know there's some patients we put in that high-risk category who have a better outcome, and we shouldn't be treating them with the same therapy, and that's really challenging to figure out who are those patients. And then there's very rare non-high-risk patients that do go on to relapse. We all have a few patients like that, and we look back and say, what did we miss? So what is that needle in the haystack? And I think biology will tell us something, and I'll show you one of the possible markers for that. And then finally, we also know biomarkers can tell us something about what's on the cell that maybe tells us there's a special therapy that can target that cell that maybe won't target every patient, but will target a particular patient. So which therapies for which patients? We also might learn which markers tell us who's going to respond to a treatment, even if it's not a particular gene. It could be a pattern of genes that tell us immunotherapy is going to work. So the other thing I think biomarkers will help us with is these in-between patients that are not necessarily intermediate risk, which I show as red, or blue and high risk, but where do they really belong? Which is important, because do you give them all that treatment or a little less treatment, and could we predict that their outcome will be the same? So these are just a few of the different, essentially I call them almost ready for prime time markers, and I'm just going to give you 2 examples. So I think we've talked a lot about this. This is just the overall schema, because there's a lot of new sequencing activity going on to look at all the DNA in the cell, so essentially what codes all of the different proteins that we get at the end. RNA is the in-between step of just what's expressed, so DNA has a lot of stuff that never is needed to make something called a protein at the end, which we've heard a lot about, and that's the ultimate sort of workhorse in the cell. So ALK, when it's finally done, is a protein, and then we'll see if it's mutant or not, et cetera. That's the antigens that we've heard about for CAR T. But you can look at all the different aspects. I think we're the most ahead in the DNA right now. So we used to sequence 1 gene at a time. Most of the time we don't do that anymore, although it's still completely possible. Most of the time, patients, especially at relapse, are getting offered in many of our centers and our countries, although not worldwide, next generation sequencing, which is when we can look at many, or in many circumstances, all of the genes that make those proteins in a cell. And I'm just going to talk about the 2 types, because you may hear about these. The whole exome, which looks at all the genes, or most of the genes that we think go on to make those proteins. And then whole genome, which is even more of the genes, they just don't all go on to make proteins. So someone shared with me this diagram to show the difference. The whole genome is like the whole apple, and about 1% of it is a really small slice, and that's the exome. Right now, we mostly know what to do with the exome and not so much with the rest of it, but I think we all want to get that information so that we can get more data. The other part to point out, and that's a schema from our Sick Kids KICS program, mostly for relapse patients currently, is that we usually want to look at both the tumor material DNA and RNA, as well as the DNA from the non-cancer cells. And that's important for how we interpret what we see in the tumor DNA. And just to point out it in the children's oncology group for the last 14 months or so, up front we've been doing full sequencing, the exome type, for all of our newly diagnosed advanced stage. So basically all of the L2s and the stage M patients get, if they consent, get whole exome sequencing at diagnosis now. There are a lot of genes. I think we've heard about ALK, so I'll go through this fairly quickly, but essentially currently the only mutation of all of those millions of genes that we can look at is really ALK, where we have some drug where we know we can use it, and at least in some patients see a response. So we find a mutation at diagnosis in only about 1 of 10 patients. Sometimes there's a high level called amplification. And we do have drugs. 2 of them are included on the right-hand side, but there's many others. Other gene mutations, so other genes being altered, is much less common, and as you've heard about from Lindley, there are fewer drugs, but there are some drugs, and sometimes we can get those patients onto, for example, platform or basket trials that aren't just for neuroblastoma, so it is important. And we may learn more about mutations that may not tell us about a drug, but tell us about a behavior down the road. We heard about people wanting to know who will develop CNS disease, for example. And finally, I have just 2 slides on biomarkers that I think are giving us more information. So we've heard a lot in the biology meetings over the last 5 to 10 years about telomerase maintenance mechanisms, and neuroblastoma, like many cancer cells, have figured out how to keep their chromosomes growing even when they're not supposed to, so that the cells, cancer cells, just keep growing and become immortalized. And in the blue chromosomes, what I've shown you is the telomeres, which are the little caps to the chromosomes shown in yellow, go away as they're supposed to over time. The telomeres get shorter, and the cells eventually will either stop growing or die. Whereas a cancer cell figures out how to outsmart that by activating these TMMs, and then you have these long chromosomes and the cells live forever. And Matthias Fischer in Germany and many others have now shown that having those TMMs, that way of immortalizing your cell, means the neuroblastoma has a worse outcome. It may be that needle in the haystack as well, maybe for the non-high risk patients who go on to recur. And many are looking at that in both the Children's Oncology Group and the SciOpen. And finally, we've talked a lot about late effects, and Ro also showed this slide from our colleague Lisa Diller, and we've already talked about the side effects, but I think importantly, there's a study ongoing with Lisa together with Sharon Diskin from CHOP and others to try to see if we can tag some of these issues or predict them with genomic alterations. So actually predict who's going to get the hearing loss, who's going to get the cardiac problems, et cetera. And finally, I would be remiss not to include work from many of my colleagues, including Kira Bona, who really reminds us that we have all these really cool biomarkers, genomics, but when it comes down to it, it's not just about that, but social determinants of health actually are biomarkers, and they're sometimes more robust than some of the fancy genes we love to all talk about. And so this is just a curve from a paper that Kira did with Ro and others in COG, and I've just pointed out that you can see the survival curve for markers of poverty versus no poverty and the difference. Lots of reasons for that, but I just highlight it because it is something else we have to think about, both in terms of something we'd want to know ahead of time, but also when we interpret trials. If there are trials and every patient on that trial has to pay to get to the center, obviously we need to interpret that data a bit differently. So in conclusion, I think all of these emerging biomarkers, and you'll hear much more about that together with sharing data, artificial intelligence techniques to put all this together, are going to inform much more robust and much more optimized risk classification, and we're trying to at least make some progress in the next INRG classifier. And so in summary, I think precision oncology has really evolved over the last 50 years to include more biomarkers. Heterogeneity, like those colorful pictures of tumors I showed you, definitely has an impact, and you'll hear more about that in the next two talks. And future biomarkers really need to not just optimize risk classification, but also go beyond that and do much more for us. And I really do want to highlight and thank the patients and families who've been a part of all these studies, who also agree to their samples being used for all of the amazing progress. And just showing one of my patients who I cared for 14 years, a real inspiration. And in terms of, we've heard a lot about translating our findings, we have a great program at Sick Kids where we bring patients and families, and often their high school or middle school classes, to the lab, and she really wanted to show her friends and the other students her cells and other things. And she was a huge inspiration on dozens of trials, both biology and intervention. So I think patients are always our inspiration. So I end with that picture. Thank you.
Thanks so much, Gudrun, and thank you, everybody, and to the organizers for the invitation. And I'm so sorry I cannot do this in person, but looks like we will navigate this online bit together. So we'll go ahead and get started since I'm a little bit behind. So really, this is pretty self-explanatory. To understand if treatment is working, we must monitor for tumor response. Otherwise, tumor shrinkage at all sites before, during, and after therapy completion. Tumor monitoring really helps us determine our next steps for treatment, like is your child ready for surgery, as well as helps us understand how and if the treatment is working. So overview for this talk is we'll talk about where, when, and how do we monitor. So we'll probably go through that quickly because you guys probably all know that pretty well by now. New disease monitoring modalities and what can we learn from our disease monitoring. So first, where do we evaluate for treatment response? Well, we need to evaluate where the neuroblastoma arises, meaning the primary tumor site, and anywhere where neuroblastoma can spread, and in other words, the metastatic sites. And we do all of this at the baseline to really understand where the tumor is so we know where to go back and look to make sure we made it go away and stay away. So primary tumor locations really arise anywhere along where the sympathetic chain arises because that's where neuroblasts come from. And so that's really what we call the paraspinal area, which is next to the backbone, which can happen anywhere in your neck, chest, abdomen, or pelvis, and often arises in your belly, in the patient's belly, in the adrenal glands. So it kind of sits on top of the kidney. The metastatic tumor locations for where neuroblastoma goes, which often will give us this M criteria. Neuroblastoma can set up shop in the bone marrow, as you've probably heard earlier today, in the setting of high-risk disease or young patients who have intermediate risk disease who are under 12 months of age. And so they set up these little tumor clusters, which can affect your blood as well as really cause sometimes pathologic fractures, but we can look for that, and we'll talk about how we do that. It can happen in other sites of the bone where the bone marrow is not. And then there's other sites of soft tissue disease outside of the primary tumor. So anywhere where lymph nodes arise, and it's not just the neck of the patient, but it can be in the chest as well as in the belly. Soft tissue lesions can be found in the lungs, and soft tissue metastatic lesions can be found in the liver. So when do we test for response? A lot of this talk is focused on the high-risk patients, but I don't want to forget about our patients with low and intermediate risk disease. But for those that need treatment, which are your intermediate risk patients, therapy duration is often flexible. We initially determine about how many cycles you get based on tumor genetics being favorable or unfavorable, which I'm sure you've heard about today, and really to understand when is it safe to go in and surgically resect the majority of the tumor. And so we call this response-based therapy. And so that's why tumor monitoring in the setting of intermediate risk disease is critical to really know when to take the tumor out, as well as when to stop therapy. So as with every patient, we get our baseline set of scans and evaluations. We give a couple of cycles of chemotherapy, and then we look prior to surgery or prior to the next couple of cycles of therapy to see, one, are you responding? And two, is it time to go in for surgical resection if there's a need for one? We always will look after surgery, because you don't want to start chemotherapy after surgery and not know what you're starting with. We love our surgeons, but when they say they get 100% out, visually under a scan might not be 100%. So we want to make sure what our new baseline is before we start giving more chemotherapy to shrink it away even more. And so really this response-based therapy makes treatment monitoring very critical at certain time points. And because our therapies are a little bit different across the pond, I'm not going to go into the different phases, but kind of pocket these into these blocks, as you can see, in the same that Meredith did, so that we make sure that you kind of have an overall global idea of when tumor monitoring should occur. So for patients with newly diagnosed high-risk neuroblastoma, treatment duration is really not flexible. Once you're at baseline and you know that you have high-risk disease, except for certain instances, what treatment is dictated by your primary oncologist is what we pretty much know you're going to get throughout the treatment. Except for when we do some tumor monitoring, that may change things. So when do we monitor for disease response for high-risk neuroblastoma? Because treatment isn't flexible, the real rationale for monitoring treatment response during the course of high-risk therapy is to evaluate for those patients that you've heard about who have therapy refractory disease. We don't want to keep giving them chemotherapy if they're not going to respond, and we may need to change things to get them back on track to responding and to a cure. We also want to make sure that their tumor's not growing through therapy. So could be a little bit more aggressive, not just responsive, not responsive, but growing. And we also use it as a way to understand when is the time to take a step back and reevaluate with your treatment team and with the family and the patient, does therapy need to change? And so when are those times? So we often will look before surgery. As I didn't put an arrow here. There are a few cycles of chemotherapy where sometimes we'll stop and take a look, but we don't often change therapy at that time. And the reason is that we change the chemotherapy that we give, both through the SIOPEN as well as through COG. And because of that, even if the tumor's not responding to the first couple of cycles of therapy, we continue on the course and trudge ahead, because we know that by changing some of those chemotherapy medications, the patient's tumor may begin to respond. And so for those of you who may be new, I'm not sure how many families are here who just started therapy, but there is a rationale for why we don't check after every single cycle of therapy, because this therapy has been very thoughtfully planned to confuse the tumor and hit it if it's not working in the first place by using a different medication. And so that's why these arrows come up, so that we're not exposing your child to unnecessary radiation or procedures like bone marrows when it may not change the therapy at that particular point in time. So always we will look before we do what we call our second look surgery, or when we're taking that primary tumor out, because surgical resection is part of our induction for high-risk neuroblastoma. Some patients are fortunate enough where their tumor shrinks all the way away. That's usually not many of those patients. And so we need to look after a few cycles of chemotherapy, usually about 4 or 5, to know if it's time to take a step away from the chemotherapy and go and get the primary tumor resected. And then we move forward with more therapy after that. Now, I boxed in this end of induction response because it's really a pivotal time point. For example, in the new Children's Oncology Group Phase 3 trial, the end of induction response is a really critical time to know how are the patients responding to each randomized arm of the therapy, and does therapy need to change, such as needing a little bit of extended induction, which we have added into it. And I know that the high-risk neuroblastoma 2 study does the same thing. And so this is a time that we look to really see how are you doing? Do you have a tumor that's responsive to chemotherapy? Did we get enough of your primary tumor out where we feel very comfortable to move forward with getting that high dose therapy and stem cell transplants? And so this pivotal point is pretty important, but yet I want to take a step back to just talk about this because this may be a question that arises in the panel. Some studies suggest that the end of induction response, how well did you do to those first 5, 6 cycles of therapy, predicts your patient's overall outcome. And I want to stress that this is very difficult to determine as this needle keeps changing as we continue to improve therapy in different phases of high-risk neuroblastoma treatment that happen after induction. As you know, we've gone from high-risk therapy to stem cell transplant to 2 stem cell transplants. Oh, wait, I think in the chat, are people able to see? Should I continue? Okay. Wait, I'm just seeing some chat. Are we okay to move forward?
Yes, perfect. Just
make
move ahead. Thank you.
Okay. So again, you might want to mute. Awesome. So sorry. So I want to stress that the end of induction response isn't necessarily predictive of overall outcome these days as we're continuing to change consolidation regimens, post-consolidation regimens, and how we radiate the primary tumor bed. So just take that with a grain of salt. However, at the end of induction, a lot of the oncologists, ourselves included, do know when it may be time, even if you're not on a study, to take a step back and reevaluate the situation. If your patient doesn't respond to 6 cycles of chemotherapy, is it the right thing to go forward into more chemotherapy with transplant at that time? And do we need to take them off route, give them something, chemoimmunotherapy, for example, to get you back on track to transplant? So the end of induction response is important, but may not predict your overall outcome because we do have options to get you back on track. All right, so then we look not often before radiation because we have a standard way of giving radiation based on your end of induction response. And we do look before immunotherapy because we know that when you give GD2 antibody therapy and cisretinoic acid without chemotherapy, which is the majority of our standard post-consolidation regimen, that you don't want a lot of disease. And so this is another critical time point to look and make sure that we're doing the right thing by moving forward. And then, of course, our goal is to get everyone to the end of therapy with no evidence of disease. And so that's why these time points are very critical to help us make that happen by making sure we're giving the right therapy to your child, both on and off study. So how do we evaluate our responses? So at the primary tumor site, the best way, because the primary tumor is often soft tissue, we look with an MRI. The advantages over an MRI to a CT scan is that it's better at detecting soft tissue differences, especially in the belly where there's a lot of soft tissue stuff going on. And so as I mentioned, here you can see a paraspinal tumor that is going along the sympathetic chain, which is really easy to see with this modality. Now, CTs are great, especially if you're coming in the middle of the night. We need to know what's going on with your newly diagnosed child. It doesn't need as long of a sedation. It still can pick up soft tissue disease, but we find CTs are often better at picking up things that are happening in the bone from a soft tissue standpoint. And MRIs can also help us understand what the tumor is doing to cause particular symptoms. And so as you can see here, this is a MRI where the tumor is along the backbone. And as you can see, it's kind of pushing into this area right here. What you may not know is that is the spinal cord right there. And so it can push on the spinal cord and cause symptoms like paralysis or weakness. And we know this is an oncologic emergency. And so it's really important to have these very clear pictures to know what to do both before we can do surgery and where's the safest place to biopsy to get our information at diagnosis, and then to follow it. And it's most important to understand that you want to stick with the same modality. Comparing an MRI to a CT is not always the easiest thing to do when you're measuring centimeter by centimeter. And these types of scans also are very good at capturing other sites of soft tissue metastasis that we spoke about a little while ago. And sometimes your doctor will order other sites, like a neck CT if you have a big neck node right there, to really look at your soft tissue metastatic disease. So we evaluate bone marrows by performing bilateral bone marrow aspirates and biopsies. So why do we do bilateral? That's annoying. Leukemia patients only get one side. And we've learned over time with many studies that this really increases the accuracy of detecting bone marrow involvement by neuroblastoma. As you see here, we usually go along the posterior iliac crest, and it's important to not only get the liquid part of the marrow, but this white part, which are bony spicules, is very important to get that biopsy, because these little goot guys right here, which are your neuroblastoma clusters in your bone marrow, these are red blood cells, these are neuroblastoma cells, they're sticky and they like to hang out around the bone. And so it's important to get those bone biopsies so that we don't miss that your patient has neuroblastoma in their marrow, because we need to make sure that we're going back and looking, and we need to make sure we know they do or don't have metastatic disease. And it's important to note that this is very difficult to look at under a microscope and know from beginning to end. And as you can imagine, like what your response is. And as you can imagine, if you test here, and then you test at different areas later on in therapy, you may miss it. And so there's sampling error. And so it's very important to note that bilateral helps avoid that sampling error for missing pockets of neuroblastoma, and that looking at it under the microscope has really been standardized internationally in order to coin a bone marrow response at the different points in surgery. So across the waters, we do it all the same way. Oops. So how do we fully evaluate soft tissue and especially bone response? So we do this by doing nuclear medicine scans, which really pick up what we call tumor metabolic activity. These scans are dependent on these cells actively taking up compounds and actively dividing. And so the common scan we use that most of you guys have heard of already is called MIBG, or meta-iodobenzoguanidine. MIBG is a molecule that mimics a receptor or a protein that gets taken up by sympathetic nerve cells called the norepinephrine transporter. And these are all expressed on neuroblastoma cells, or at least 90% of them. What happens is we take MIBG and we radiolabel it with a radioisotope called iodine-123. And that allows us to put the patient through the scanner after we've injected them with the systemic dye, and it picks up these sites of disease, both in the bone as well as the soft tissue. And we've learned over time that it's incredibly sensitive for neuroblastoma and another type of tumor called paraganglioma. And at low dose, we can use it for radiologic detection, as you see here. But we've learned over many years that if you really increase the dose and replace the iodine-123 with a different radioisotope, iodine-131, we can actually use it as a therapy, a systemic radiation, which you may have already heard about in relapse treatments, to eradicate really aggressive disease. And so what we also know is that if you take this SPECT scan, which this is a 2D scan, it's a 3D scan that's called a single photon emission CT. It helps us really localize those sites of disease so that we can follow them very closely. So how in the world do we measure this? That's a lot of spots, right? And there's actually some spots that naturally show up that are not disease. And so our radiologist, in collaboration with neuroblastoma oncologists across each continent, have come up with a way to score different areas of the body for those sites of disease based on how many sites, how much of the bone it takes up, and whether there's soft tissue involvement or not. They take these and give each site of the body a score and then add up that score. And so it becomes known as a SIOPEN or a Curie score. And you've probably heard of these scores. What it does is it allows us to really monitor how many spots you have, your child has over the course of therapy to know if we are really doing a good job at not just shrinking the disease, but improving the response metabolically. So what about those patients whose MIBG scan is negative, but we know they have high-risk disease by seeing soft tissue all over the body, but it's not picking up by MIBG? We're very lucky and fortunate that we have other scans that can detect both bone and soft tissue disease in our neuroblastoma patients, such as the PET scan. So the PET scan is a little bit different than the MIBG scan in that it's a scan that has a radioactive sugar called FDG, fluorodeoxyglucose. So that's taken up by highly metabolic cells, cells that are proliferating, cells that are working really high, like your brain, all the time. And so it's not as selective as an MIBG scan for neuroblastoma. And so it can light up in areas of infection. In other tumors can pick up PET, and it can also be taken up by normal organs that have high metabolic activity, such as the brain and the liver. And so it's used when neuroblastoma MIBG scans are negative. Again, we can localize it by using a CT scan and superimposing that PET scan on that CT scan. What's important to note is that when you start with one scan, you continue with the same nuclear medicine scan. And that's really important because they're not equal. It's comparing apples to oranges. And sometimes some of your doctors may tell you if you go somewhere else to get a consult and get disease for your patient with relapsed neuroblastoma, the PET scan at one site may be different than the PET scan at another site. So you just have to take all of that into consideration as these scans are being read and interpreted by the radiologists and the oncologists. So there's actually some new nuclear medicine modalities on the horizon. For example, there's a new nuclear medicine scan called MFBG scan. It's metafluorobenzoguanidine. And MFBG can detect similar but often more lesions in patients compared to an I-123 MIBG scan. As you can see here as an example, this is a patient's MFBG scan. You can see it's really crisp compared to the kind of grainy MIBG scan, and that there's a little spot here that if you look on this slice of the skull, there's a scan that lights up by MFBG, but a site, excuse me, but it doesn't light up by MIBG. It doesn't mean that between these two scans that arose, this is just a little bit more sensitive. The other aspect that might be beneficial, especially for our little toddlers, is that the scanning time is shorter and may not need sedation. There are studies internationally and nationally here in America that have been done that have proven that it seems to be more sensitive. However, we are continuing to study this modality, and there's a study that should be opening through the Children's Oncology Group to really compare side by side these. And really, we have to take a step back. We can't suddenly just throw in an MFBG scan and know what to do with it and how that's going to help us predict end induction response and what we do next and what does this mean? We have to really look prospectively with both scans with our current therapy to understand how to start to incorporate these new and more crisp and better modalities into our line of therapy. And we did this with MIBG from bone scans. I remember I'm that old. We used to use bone scans sometimes. So, we will get better, and these are really coming close to being incorporated into our trials. So let's take a step back now that we know how, when, and where. What does this all mean? So assessing the primary tumor and metastatic sites is critical when evaluating treatment response in neuroblastoma, as a patient may show a good shrinkage or a fantastic resection at the primary tumor site, but still have a lot of active metastatic disease. And just as metastatic involvement can significantly impact the risk of a patient with neuroblastoma, it can also influence the patient's prognosis. So in general, a good response at the primary tumor site alone is great and can maybe happen just because of surgical resection alone. But if that patient continues to have a significant amount of metastatic disease, that is still an area of concern. And so we want to make sure that we're monitoring all of these and that we do celebrate those successes, such as a primary tumor shrinking really down. But we want to make sure that we're eradicating disease at all sites because the metastatic tumor response is very important for ensuring an overall good prognosis. Oops. And so here, I want to really take a moment to show, as Meredith was saying, heterogeneous disease is also very evident at the microscopic level, at the treatment response level, but also at the tumor response level as we're monitoring those responses. And so here's an example of tumor heterogeneity as we're using our different modalities to understand how did our kid do in response to that particular therapy that they just had. So soft tissue may lose MIBG avidity, meaning it goes completely MIBG negative, but not change in size. And this is likely due to maturation of the tumor. And so that means that you still have a very robust response and the patient's benefiting from treatment, but we're not necessarily able to call a great response because it didn't shrink down. And we're using these response criteria that we developed many years ago and that may need to be optimized, which a lot of us are in the process of doing as we speak. So let me give you an example of that. I ran a trial with lorlatinib, which is an ALK inhibitor, and we had patients that had amazing responses to MIBG. So if you look at this line, these bars right here represent each individual patient, and they show that a patient here, I guess we'll use this one right here, had their Curie score, which was about 15, go from 15 to 0. They had 100% response of their bone and their soft tissue disease, including their primary tumor, to the treatment being lorlatinib for their ALK mutated tumor. However, if you look at the color of the bars, even though all these patients had 100% MIBG goes negative, many of them did not have a complete response called of their overall disease. And here's why. So this patient number 11 right here, here's their scan. And trust me, there's a soft tissue mass right here in their masseter muscle. And so here's at enrollment and here's at course 4. You really don't see a whole lot of change. However, if you look at the MIBG scan, it's incredibly avid for MIBG here, but then the MIBG goes completely away. And just to orient you to an MIBG scan, these sites right here and here are normal. Parotid glands naturally take up MIBG. But this patient who had single agent lorlatinib actually continued on lorlatinib for 5 years and is now off of therapy with no evidence of disease by MIBG. And this lesion has never, it's right there. This lesion has never gone away and they have a fantastic quality of life. So we really need to think about that as we're monitoring our patients for response, especially in the setting of targeted therapy and in relapse disease, to really know, are they benefiting from this treatment and should we continue on even though overall we're deeming them stable disease? And so we really believe that this response is real, and our International Neuroblastoma Response Group, who are come up with these different response criteria, because of what we see, have deemed a new type of response called a minor response, which we all believe is a very legitimate and robust response. And as such, this is being carried forward into a lot of our disease states to understand how neuroblastomas are responding to therapy. As Meredith said, along with different responses noted in targeted therapy, we can also monitor for changes in the genetic makeup of tumors once targeted therapy is started. We can do this by testing the tumor tissue for changes. So genetic sequencing of the tumor is really a lab test, as you may have already heard, that analyzes the DNA of a tumor to identify tumor-specific mutations that may be targetable with a novel drug. For example, the previous slide, ALK mutations found in a tumor, we start an ALK inhibitor. But how those patients are responding, we usually get our standard testing, as you saw before. But there's also opportunities, and it's almost become the paradigm of clinical care, to genetically sequence a tumor that relapses following both standard and targeted therapy. And why do we do that? It helps us identify why patients progressed, and it often may identify new targets that will restore sensitivity to either that ALK inhibitor or to that standard of care by adding on an ALK inhibitor when we notice newly diagnosed ALK relapse disease, ALK mutated. However, it's not always easy to biopsy a tumor during therapy. There may not be enough tumor and it may not be safe to get at. And so there are coming down the pike that Dr. Tytgat will talk about next is we're really excited about this liquid biopsy approach where we can really get at the heart of understanding how these tumor-targeted therapies work, how standard therapy work over the course of time by serially collecting these samples both during therapy and at the end of response or when their disease progresses. So I won't go into that anymore. So I will try to be quick because I know we're running over. So in terms of GD2 therapy, GD2 is tough to capture on tumor slides because it gets broken down. There's no standard method, as I believe Nick was asking what are our better biomarkers to know who can respond to GD2 therapy, because patients don't want this therapy that causes resistant disease, symptomatic disease. And we need more assays to be able to understand GD2 expression. And that's because it can be heterogeneously expressed, and it can sometimes go down on the tumor after therapy. But I want to really highlight that we're coming up with new ways to be able to detect GD2 on the slides, to look at circulating GD2 in our plasma of the patients, as well as to detect bone marrow tumor cells and look at them by GD2 expression over the course of therapy and when a patient's tumor progresses. And then also to look at our immune cells and understand how they change over the course of immunotherapy to also determine biomarkers of response, both the immune cells in the tumor as well as the immune cells in the patient's peripheral blood. And does that immune cell makeup predict the patients who will be best benefit from GD2 targeted therapy? So these are hopefully, as Meredith mentioned, new things coming down the pike. And so I think I'll just finish very quickly with knowing that tumor response monitoring is critical. And it's important to understand the best treatment approach for each patient so that we can individually tailor so that they all get to a cure. All sites of disease need to be reevaluated at certain instances, especially in the high-risk setting, to understand where it's at, has it gone away, and are new areas where it wasn't previously, has it progressed there. And that targeted therapy response monitoring may be changing in terms of what we call a response and can identify potential new therapies to improve outcomes. So, and it may also help us tailor our immunotherapy. So thank you to our patients and parents, and I'm sorry I ran over, but I appreciate you letting me talk for as long as I have. And I'm leave it back to Gudrun.
Thank you very much for this outstanding talk. And now it's my pleasure to introduce our third and last speaker in this session, Lieve Tytgat, who will be speaking about liquid biopsies. Thank you.
Thank you so much. I really want to thank the organizers for introducing or having this great symposium with the parents all here. I'm really excited to talk about the liquid biopsies. So first, who am I? So I'm the person in the middle. I'm primary clinician, and during all stages of my training, I performed research, and I realized that I've also always been teaching. So I think learning from the patients in the clinic really also raised the questions, what do we need to investigate in our studies, and really what can we translate back to the clinic again? So today I will talk about liquid biopsies, and everybody thinks liquid biopsies is cell-free DNA, but I want to broaden the definition a bit. I will first introduce you 3 forms of liquid biopsies. One is the messenger RNA, the urinary catecholamines, and the cell-free DNA. I want to discuss with you what can we learn from these liquid biopsies and also the future perspectives. I think it has been raised many, many times. So what is actually applicable to my kid? Because we have like different studies, different trials open, but also we perform really different analyses. And one analysis can show a CR, but the other analysis can show a sign of disease. So what do we take into account? What must we believe? Should everything be cleared, or how to proceed with this? So I think we have already learned a lot about biology, which is very important. We know also that MIBG scans or imaging is very important also for response assessment. And Kelly also already showed that the bone marrow is a very important organ, because most of the neuroblastoma, high-risk neuroblastoma, are metastasized to the bone marrow, and most of the relapses, recurrences are also in the bone marrow. So it's very important to really know if that's cleared of disease. So today I will talk about first the messenger RNA detection in the neuroblastoma, in the bone marrow and the blood. Secondly, I will discuss the catecholamines and then the cell-free DNA in the neuroblastoma. I think this scheme has already been shown before. So for high-risk neuroblastoma, we have an induction treatment, the consolidation and the maintenance. And I will focus today on diagnosis and end of induction to see how can we assess the metastatic response. Ideally, if we have one tube of blood or bone marrow, when we do the centrifugation step, we will have the cellular fraction and we'll have the plasma. In the cellular fraction, we can investigate the tumor cells, which can be the disseminating or metastasizing or circulating tumor cells, but also the immune cells. So we think this fraction is very important. And on the other hand, the upper part is the plasma where the cell-free DNA is located. So we have samples which we actually divided like this, and we can then investigate the tumor cells, the messenger RNA versus the cell-free DNA in the identical samples. So messenger RNA is genetic information which in the nucleus of the tumor, and we have neuroblastoma-specific messenger RNA panels, and with that we can see if in the bone marrow or the blood there's still messenger RNA detectable of the neuroblastoma, ergo if there's still tumor cells in there. And we can look at diagnosis and end of induction. So this is a slide from Sue Burchill from the SAIPAN high-risk 1 trial, where actually she showed that if the TH and FOX2B, which are two messenger RNA markers, if these are highly detectable at diagnosis, the patients have a very dismal outcome. Of course, this is high-risk 1, so we are now validating this in high-risk 2, if these levels indeed correlate with poor outcome. And in a different chemotherapy background, the German-Dutch background, we also performed a validation study, a bit different, but again, also the same markers. And here we actually show that high levels of bone marrow invasion with the messenger RNA correlates with poor outcome. So we validate actually what Sue already also has found. So the question is this mere high levels of disease, high disease burden? But then again, if the patients have a high disease burden at diagnosis, would we treat them differently? We don't have alternative treatments for now. So what are we going to do with this? I think we don't have the answer yet, but it's good to know that we are looking into this. So I think end of induction, metastatic response is more important to see if we can identify the patients which might do well and patients we might need, for example, the double transplant or so. Can we help to answer that question? So this is end of induction in the German-Dutch cohort, where we actually see that any level of positivity correlates with a poor outcome. So these patients were treated mostly prior to immunotherapy, and despite the overall survival of 5 years of being about 35%, we really can identify if the patients the bone marrow is cleared of messenger RNA, that the patients have a very good outcome. So this was with the high-dose chemotherapy and the retinoic acid maintenance. So what would the numbers be if we also treated these patients with immunotherapy? Are those the ones that might have 80% or 90% survival? We don't know. And in high-risk 2 trial, we are validating these findings. So we think this is a very important next step. As standard of care, looking into the bone marrow, the patients were tested with immunocytology to see if the bone marrow was cleared of disease. So the green dotted line is immunocytology negative patients. From the same samples, we have the leftover material, and we tested these for the messenger RNA. And actually what we can clearly see, if the messenger RNA is positive in the sample, we think the event-free survival is 55%, but actually if the PCR is still positive, the patients have a poorer outcome. But if the PCR is negative, the bone marrow is cleared of disease, the outcome is much better. So we show that the qPCR is a really sensitive technique, more sensitive than the current standard of care to detect if their bone marrow disease is still detectable. We know that end of induction MIBG scores are being used in the SAIPAN to stratify for treatment. So this is for only a Dutch cohort where we tested end of induction MIBG scores, and I apologize, here we have the cumulative incidence of events. So the higher it is, the worst outcome is, because here the patients with MIBG more than 3 have a risk of an event of 68%. Whereas the patients with lower than 3 have an event risk of 40%. So 60% we think will be cured of disease, so we'll have no relapse. But from these patients, from the same time point, we also have the bone marrow samples, and we tested these for the messenger RNA. So here's the dotted line again. And if the patients with less than 3 MIBG have a positive bone marrow, we think now they have 62% chance of an event, so only a 40% chance to survive. And if the bone marrow is cleared of disease, then the risk is much lower. So this is also to identify that even in the patients with MIBG lower than 3, the bone marrow testing can really identify the patients maybe that need other alternative treatments or chemo, immuno, or other treatments there. In the patients with the higher MIBG scores, we only had 4 patients which were cleared of disease, so we cannot draw any conclusions here. So next, we move to the urinary catecholamines. So every country, every lab has their own technologies, their own cut points, their own panels. So therefore, in the INRG response criteria, people said, well, we don't know how to deal with this, so it's been left out. The lab where I worked in actually tested not only the VMA, HVA, what everybody knows, but we tested all the other markers. You don't need to remember the names. But what we clearly saw is that if we saw that these markers were highly detectable in the urine, it mostly was a good patient with a good outcome, so non-high risk or ganglioneuroma. And if the markers here were highly expressed or highly detectable, it mostly was an aggressive one. So therefore we initiated this project funded by Villa Joop to see how can the catecholamines help us further. So one of the things we did, so we established a SciOpen committee. Together with the SciOpen members, we thought, should we still use the 24-hour collection? Because we all know, and I think you as parents all know, 24-hour collection is a nightmare. We have the plastic bags that stick, and then you pull it loose, and the skin is breaking down, and then we lose one collection, and we have to start over. And also the diet, we didn't think it was very useful for the patients. So we show in this paper that we don't need 24-hour collection, so we can use spot urine no matter which technique you use, and we don't need a diet anymore. So we think this is a very big step forward. We also showed that if one of the left markers is high, that the outcome is poor for these patients, and also that it correlates with MYC amplification. So this means that in the urine we can already see if the levels are really high that there is a MYC activity. It's MYC and mostly it's MYC and amplification. And so this has been recently published. So we think patients are in complete remission, but still about 50% of the high-risk patients do relapse. So how do we know if somebody is really free of disease or not? So what we did is, it's a small trial, it's only Dutch patients, but we took all the moments where we said, okay, complete remission, and we had the urinary samples, and we classified them according to catecholamine positive or negative, so negative or positive. So at the moment of complete remission, if the catecholamines are negative, then actually the patients do have a good outcome. So this is a high-risk cohort, a current high-risk cohort, and here we have like about 80% survival, which I think is amazing. But if the catecholamines are still positive, then of course the outcome is poorer. So this is something we want to validate also in the high-risk 2 trial, and we are thinking, should we reintroduce the catecholamines back into the INRG, because everybody is measuring them, and they are there, so why not make use of this? So this will be a follow-up project again. So the final part of my speech is about the cell-free DNA, which everybody really thinks are the liquid biopsies. And this is about the cell-free DNA, which is detectable in the plasma. So tumor cells shed DNA. There are also 2 publications that show that they also actively excrete DNA. So on one hand, we perform all kind of genetic testing of the tumor biopsy, but we can also use these for the liquid biopsies, and we can test these for various ways. So what can we detect in the cell-free DNA? We can find point mutations. So the ALK aberrations have been already described, but there are also other which might be important for ALK resistance, so for ALK inhibitor therapy, or other high-risk phenotypes. A copy number alteration, so MYC amplification, but other amplification, but also like the chromosomal gains and losses, which we think are really correlated with high-risk phenotype, we can also detect in the plasma of these patients. chromosomal rearrangement, and methylation changes. So this is work that has been pioneered by Gudrun and her team. So in 2016 and 2018, she already showed that if we look at tumor at diagnosis and the cell-free, that there are aberrations which are overlapping, that there are some only found in the tumor and more in the cell-free DNA. And when the patients are thought to be in complete remission, there was also sometimes still something detectable in the tumor, and at relapse, of course, novel mutations or novel SNVs popped up. And also that it's feasible to do sequential sampling, which is just a blood draw, and most of these patients have a central line, so then it's even not too much imposing on the patient, and we can learn a lot from this. So there have been many publications from Europe, but also from the COGs, that show what we can actually do with the cell-free DNA, that we can use them for response detection. Again, during treatment, sequential analysis, that we can find who will respond and if there is a resistance occurring. And also in the MAPI-X, I apologize, I cut a point, the last point. And also transatlantic, there are nice publications that really show how to work with the cell-free DNA and how we can do this. Also, the high levels of cell-free DNA at diagnosis correlate with poor outcome. Again, the question is, what can we do with this and how will we use this in our future trials? Future directions. So liquid biopsies have been discussed in high-risk phenotype and high-risk trials, but what about the non-high-risk trials? So the German NB 2015 is currently nearly final to start, to open up. It's a low intermediate risk trial, and there the catecholamines will be validated to see if they can identify high-risk phenotype. Cell-free DNA diagnosis will be tested to look at chromosomal copy number aberrations, and the messenger RNA will also be validated in the trial. Finally, a few moments about Mona Lisa, the project. Mona Lisa is a project or a clinical trial where we want to investigate the use of liquid biopsy, cell-free DNA and messenger RNA in a relapse setting. So this is a project that is funded by EU, and it has several work packages, and together with Sabine Taschner-Mander from Vienna, we both lead the study. So what we actually are wanting to do, our dream is that we want to have liquid biopsy serial testing in the future, and that when we see something in a liquid biopsy pop up, that we then go for the imaging, so that we don't do the standard imaging like every time, but only liquid biopsy-based imaging. So this is like the dream that we have. So in this trial, we will randomize 150 patients after a first event. One arm will be monthly liquid biopsy testing, and the other arm will be standard of care, just normal imaging and normal testing, and liquid biopsies will be taken but retrospectively analyzed. So in the arm where we do the monthly liquid biopsy testing, we aim to report within 2 weeks, which will be a challenge, back to the clinicians if we think the liquid biopsy shows an indication of a molecular event. So is a liquid biopsy positive? Do we think anything is there? And then we will give the advice to the clinician, please perform the imaging. So we hypothesize that in this trial, liquid biopsies can identify an event 5 months before the standard of care imaging, which of course will be a challenge because there will be moments that we will perform then the imaging, if that's correct, where nothing is yet to be seen because we are too early, liquid biopsies are too sensitive. So in this trial, we will test the messenger RNA versus the cell-free DNA, and this will be done in work package 3, led by Sabine Taschner. So in Europe, we work in a federated way, so we don't have one center or one lab where everything will be sent to, because we think it's better for the whole of Europe that there will be that each center of many centers will develop these tests, because then more patients will have access to this. And in many centers, there is already sort of liquid biopsy panel out there, which is mostly for adult patients. And those centers cannot go for a tiny disease as neuroblastoma and change the whole workflow. So we will use what is there. And in Sabine's work package, we will align the different panels and see what's the overlap. So we're currently doing this. And we will perform round-robin settings to actually show that each lab is really identifying the same targets and the same aberrations. And I think doing this, it will also show how robust the liquid biopsies and cell-free DNA are, so that we don't need only one approach, that the different approaches will be able to show these aberrations. And then also we can also see what's the added value of the messenger RNA versus the cell-free DNA, because we have shown in 2 publications that sometimes patients are only positive in the messenger RNA and sometimes only in the cell-free DNA. Of course, these are different patients. So do we need both tests? We don't know. We will find out here. In work package 4, we will use the historical data to learn more about this, and I think very important in work package 5, we'll align all the databases, and this is led by Gudrun, and also make a tool, a trial support tool for the clinicians, a decision support tool to help also the clinicians after this trial to work with liquid biopsies, because if you will have such a result, what does it mean? How to interpret this? What can we do with this? And work package 6 is also, I think, a very important work package, because what does it mean for you, for the parents and for the patients? Some parents might be really happy that monthly testing will mean that you really know what's going on and you will be secure of something, how it's going. But for other people, it can really be a nightmare for monthly testing. Like every month you think, oh my God, is it still going, everything is going okay? So at entry of the trial, we'll also have a questionnaire to see who are the parents, who are the patients, what is the family situation, because then later on, when the patients are really eligible to enter the trial, we really want to see also what's the percentage of patients which will not participate, and why is this? Is it because of financial problems, socioeconomic problems, long distance from the hospital? So that's also something we really want to find out. No, wrong one. So I think we also touched on the GD2. We are having many GD2 targeted treatments, but we don't have a standard way to measure GD2. Circulating GD2, so like in the plasma, it's GD2 on the cell surface, on the primary tumor, and circulating, disseminating tumor cells. So together also with Juliet, we are working towards like a harmonized and standardized approach within the SciOpen. So this brings me to my summary and conclusion. The RNA panel is a very sensitive method to measure if the bone marrow, but also the blood, is cleared of disease. And we think this is superior than the standard of bone marrow testing and MIBG. So we really think we need this to add to our panel, maybe instead of other bone marrow testing. The urinary catecholamines, it's a diagnostic tool because every lab uses it, but it's also a very sensitive tool to establish complete remission, yes or no. And cell-free DNA, I think what we truly call the liquid biopsies, I think they are there. The only thing is we have to learn how to work with this and to validate this in a large set of labs. Thank you for your attention.
Thank you very much, Lieve, for this excellent talk. Now I would like to invite the speakers of the session to come up for our panel discussion. I would also like to invite Dr. Sally George from Royal Marsden and ICR to join the panel discussion, and Fabio Benigno, parent and advocate, who will also join. For your information, very unfortunately, due to technical reasons, Kelly Goldsmith, who has joined us from Atlanta, cannot join the panel discussion now. And I think we have authorization from the organizers to add 10 minutes to the panel discussion because we lost some time due to the technical reasons. So that means we can go on to 1740 for the discussion. Thank you. And with that, I would like to open the discussion and ask if there are any questions to our panelists. Yes, please. And may I just invite you to speak closely to the microphone? I had heard that was important for technical reasons. Thank you.
Hi, my name's Aaron Mellon-Jameson. I'm a bereaved parent. I think we spoke earlier about one of the main factors of a successful outcome for high-risk patients being entering immunotherapy with complete remission and leaving it with complete remission. Some of the innovations around monitoring biomarkers and biopsies is one of the main opportunities to use that 12-month window before immunotherapy to either optimize or change treatment to increase that number of patients entering complete remission?
I think it's a question to several of you. Meredith, would you like to start? And then Lieve and Sally might
and then maybe, you know, I think we've traditionally in the Children's Oncology group said that as long as patients are responding, so not progressing and at least have a PR or partial response, that we see benefit to immunotherapy, even though you're right, a CR would be a bit better. So I think what we're studying on our brand new study, 2131, that's been open a little less than a year, is understanding for patients who don't have as good of a response at the end of induction, if taking a small detour, in this case potentially with chemoimmunotherapy, might improve their outcome so that then they can loop back in and go ahead with, you know, the next parts of their therapy. We think it's important to study that. Often that group of patients, like in CFN who got TVD in the old studies, don't always get studied in the same way. We actually had to fight with our regulators to be allowed to study that group of patients, but we think it's important to see if this detour and then getting to a complete response or a better partial response makes a difference. Now, how we'll incorporate cell-free DNA, which my colleagues are more expert than I on, will be complicated because we didn't study that in the past. So I don't know if one of you wants to.
Lieve, would you like to add on comments? And then maybe Sally, you would like to add things.
The Memorial on Kettering already published data, I think 10 years ago or maybe more, on immunotherapy after the high-risk treatment, so the end. And they showed actually that patients were messenger RNA still positive, a slightly different panel, but I think it's really sort of the same, and become negative after 2 courses have also very good outcome. So with that knowledge, we don't know if we really need to be in complete remission with what we are discussing now, so messenger RNA and the cell-free DNA. So this is something we are studying in the high-risk 2 trial, so the Neuroblastoma trial, where we do the sequential sampling for the cell-free DNA and the messenger RNA, and if the bone marrow is still positive, so then it's also taken along, so to be able to answer how clean is clean, and what's needed really to go to the 100% survival.
Sally.
Thank you. And maybe Sally, you want to add on to that?
I guess coming back to your question about being in CR at the beginning or the end of immunotherapy, our scans are only so good at knowing whether or not we're in CR at the end of immunotherapy. So I guess my hope moving forwards is that we can say, okay, the scan's negative, but out of those patients with negative scans, can we use the blood-based biomarker tests to say, actually, you really do have no evidence of disease, or actually maybe you are at a higher risk, and that could maybe feed into sort of further maintenance treatment and you know, a different approach for that group of patients. So that's where I would see these sorts of biomarker tests.
And I think we're doing those studies both, you know, in the past now, in our last study in the COG and your last study in the CFN, to look to see, because we have cell-free DNA collected, to say now that we know how patients have done, or well, we're soon to know how they've done, we can go back and then see if the cell-free DNA was a better biomarker than the MIBG scans or added anything.
And I think the challenge will be there, because it will be a group versus group. Can we actually study it in individual patients? So we will have access also through the bioportal to the data of one patient, and we can study side by side. So I think this is really very important to also look at that.
And it goes back to what we have mentioned several times, the importance of data collection and going to big data sets to enable really the integrative analysis of many parameters, many biomarkers together.
I guess just one more thing to add is, first of all, I think we need to look back and understand on patients that we have outcome data for before we can start to implement it moving forwards. So.
Yes.
And maybe I can comment on that. So this is something we are going to do in the Mona Lisa. So that's the retrospective cohort. So what's already out there, what we already have collected, that we already learned. So that's not wasted data that we learned from these.
Thank you. Are there any other questions from the audience? Are there any online questions? Yes, please. Yes.
Thanks. Yes, we have a question about variant allele frequency and tumor fraction results from ctDNA. Can you explain what they are and how they can be interpreted?
Yes. So, Sally, you want to? Yes, go ahead, Sally.
When we talk about tumor fraction, what you have to remember is that both healthy cells and both tumor cells will release their DNA into the circulation. So the DNA that we sequence will be partly from the patient and partly from the tumor. So we have tools to measure how much of that DNA we think is derived from the tumor versus derived from the patient. So when we look at these, and then variant allele frequency is looking at, when we look at the tumor-derived DNA, actually how much of that DNA has the mutation versus does not have the mutation. So we have to look at all of those factors to try to infer, well, actually, how much tumor DNA is there? Of that tumor DNA, how much has that particular mutation? So I guess it's a very insightful question and a very good way of reminding us all that it's never that straightforward, and we have to look at all of these parameters quite carefully.
And maybe we can add on to that, just as we have learned for the MIBG to work on a score and develop a score, we will need to do similar work. And Lieve, you explained we will be doing that in Mona Lisa to define cutoffs and to know what shift in the variant allele fraction actually corresponds to disease progression versus a disease response. So far, we haven't really defined these cutoffs yet, and work is ongoing. Do you want to add anything? Okay, thank you. I see there's a question here. Yes, Nick, please.
Hello. So with the blood-based analysis and markers, so we've seen with imaging with MIBG scans that we have, clear scans or not clear scans, but sometimes we have not clear scans, but actually if we scan by something else, it's clear. And if we still have some things on scans, maybe we don't need to treat because we've tipped biology. When it comes to blood-based markers, ctDNA, when we're talking about, to your point, Sally, about a completely clear, is this the binary thing that you have something in your blood and you need to keep treating until there's nothing in your blood? And to the extreme point, if we did liquid biopsies in low and intermediate risk tumours where we just give children a little bit of chemotherapy and maybe a bit more and want to tip them over the edge, what would you expect to see in their blood-based biopsies?
Who would like to answer? Lieve?
Yeah, so I think maybe start with the last question first. So the non-high risk, so the low and intermediate risk patients, the question is how much will there be detectable? Because we also think that the more aggressive tumors will shed more. So this is something we have small data cohorts on, but this is something we're going to actually also study in the German low and intermediate risk study to evaluate what's there, what's detectable. And can we use it the same way if there's a peak or whatever, like in the high-risk patients? So the true answer is maybe it's different. Maybe we do not need to do it in the same way because the biology is really different.
Maybe just an additional information. As for MIBG, we have MIBG non-avid tumors. We know that even in the high-risk population, it is not just a question of tumor volume and overall tumor burden, but we have maybe 10 or 20% of tumors that, for whatever reason, don't seem to shed any cell-free DNA at all, or we can't detect it. So I think there are still other mysteries, other biological information that we need to unravel before we can include the overall cell-free DNA information into our overall response criteria. But we need to collect the information. Yes?
Gudrun, I wondered, since Fabio is here, and I know his child has been treated for a very long time, I wondered if he had any thoughts on some of these tests and whether you've had an opportunity.
I thought you were going to ask me a biology question.
Oh, I looked a little nervous. I don't know.
'Cause I'm a literature major, so.
Okay.
Well, it's, my son has been through treatment for almost 10 years. So obviously we've sat through many scans, and we always wish that there was a better way of assessing treatment, response to treatment. And I've been, watching and seeing the development of these new ways of detecting. So I was in a panel, but I had this question whether any of you will see this as replacing some of those scans, for example, that will this become like more reliable in terms of assessing of measuring the treatment response? Because I know my son has been through a lot of the every time he goes through a scan, there's obviously the radiation and all of that, and so we wish that there's a better way, a more effective way, and also one that doesn't harm him more than the rest of the treatment already does. So yes, I'm very interested in fact, I was my son when I sat at one of these conferences. It wasn't here though, and I heard about this the liquid biopsy. And I went back to Portugal and I asked Tiago's doctor about whether or not we could actually do it, because he always relapses in very small sites, and it's always really hard to biopsy those sites. So we were always told that the information, it would be really hard to get anything out of it. So, and then I heard about liquid biopsies, and so we went back and he did the first one maybe about 6 months ago, which didn't yield any results in terms of aberrations or any, but at least it's something that we didn't know whether or not we actually had that the setup to do it in Portugal, but they did, but I think it's great to see that now. My question is, I've got two questions for any of you. Whether you will see this replacing some of those imaging, and also whether, because for us the problem was, once what do you do with that information, like in terms of because I don't think they were looking at, I hear from certain groups that they look at a number of genes, of alterations and everything, and we didn't know whether they were doing the same job, whether they were they had the same sort of to compare.
Yeah. Can I start? So, yes, I think ideally we would really want to replace the standard imaging, like every so many months, with a liquid biopsy testing, and then if there's something to be found, that we then say, okay, now it triggers the MRI, MRBG, or well, hopefully it's MFBG by then, but so that it triggers then the full examination. So I think this is really our dream. This is really what we're working towards to. And the second question was, so actually what we are doing in Mona Lisa is also comparing the panels, because they're mostly adult panels. There are some also now pediatric panels. Not all the genes are the same. Right. So we think actually the different panels will really find the important things, but this is something we also will validate in SciOpen and also in Mona Lisa.
And you're also comparing to the scans, right?
Yeah.
To see sort of the relative.
Okay. Yeah, because the idea would be, I mean, there is another parent here from Portugal, and we feel that we are somehow, people need to do something about it. First of all, entering into clinical trial. We know it's a small country, but it's still, we could, that's not the reason why we are left out of some clinical trials. It's just a matter of organization and everything. And we would love, for example, if there was no capability of looking at that sample and comparing with the panel, I mean, it could be sent somewhere where there's more expertise or any more data collected that could be helpful for us. But that's something that we need to take back home and advocate for.
That's a good
Maybe
point.
I may say, as already pointed out, in SciOpen we really have a federated approach to all these analyses, and I think that's crucially important as you're underlying also. So we have been working in a SciOpen biology group and SciOpen translational research group, and we have representatives from all SciOpen, all European countries. Portugal also, there are people participating in our biological studies, and I think there, as you say, really having the possibility to have access to the biological analyses, or if it can't be done in a country, knowing where to send it is something that is crucially important. The other point I wanted to make when we're talking about liquid biopsies, just so it's clear for everybody, is in fact we're using one word but for two different things. We're using this term on the one hand for what we call monitoring of disease, response or not, but on the other hand also just at the time of relapse or progression, using these techniques to know if there's a targetable alteration that has been mentioned several times here. The most ready to use one, or already ready for use, is ALK. And so at each progression to do a liquid biopsy, just to know if an ALK mutation is there. I think that is standard now in most countries, or nearly standard, on the last step before standard, and I think that is really something that is really important. But again, it's one test and it answers, two different questions. Yes. Yes, please.
Just to make a comment, because you mentioned about your son not having a biopsiable site, for example. And so the way we're addressing the serial sampling is through collaboration within SciPen and the Mona Lisa program. I think at the time of relapse, then, as Gudrun said, ctDNA analysis is a really good option. So for parents within the UK, the SMPEDS2 program will open very shortly, and at the time of relapse, we will actually report that liquid biopsy result for this very reason, that if there is an ALK mutation or something that could be actionable, so that we would report that ctDNA result at the time of relapse. The serial sampling is more nuanced, needs much more careful evaluation, and therefore we continue to work collaboratively. But I think within lots of countries within Europe, at the time of relapse, we're very close to being able to report those results now.
Yeah, and we in Toronto, we have a protocol led by Daniel Morgenstern, who many of you know, and Sarah Cohn-Gogo, to take hard to biopsy, impossible to biopsy lesions and get a clinical report from the ctDNA, and are studying whether that impacts therapy.
Thank you very much. I think we're coming to the end of the session. No other questions? Oh, yes, one, please, Donna. Yes, the last one then.
Right, thank you. This one came in, Meredith, when you were talking about MICN and how that affected risk stratification. The parent wants to know, is MICN amplified the same prognosis as a stage M non-MICN amplified, presumably over 18 months?
So when we looked at this in the children's, so the question is sort of, once you're over 18 months, I think, and stage M, does MICN matter, if I can paraphrase it? When we looked at it for the whole group of patients in the children's oncology group, so we had 5,000 total patients, and about 40% of those were stage M. We didn't see a Kaplan-Meier effect just in that group. So when we looked at everyone, I think if we were to do a analysis where we looked at multiple factors with MICN, we might see something, but I think the real answer when we look at the group is it probably doesn't change anything. I think most of us think MICN changes the behavior, and maybe those patients who have MICN amplification, they have a lot more cell cycling, cell division, so they seem to sometimes respond very quickly, and if they do progress quickly versus the non-amplified. So it definitely affects behavior. It may affect that refractory relapse kind of ratio, but just for survival, at least in our cohorts, we didn't see it as one factor affecting survival.
Can I add to that? Yeah. That what you say, they respond quickly, but also relapse quickly.
Yes.
So if we look at response criteria, end of induction, MIBG scores, these will be in the lower than 3 scores, but might indeed relapse quickly. So maybe we also should rethink how to apply those response criteria to the MIC amplified versus non-amplified.
Yes. Thank you very much. And with that, I would like to close this session. I would like to thank the speakers and the participants of the panel discussion for the very nice discussion and the wonderful presentations. Thank you also to Dr. Kelly Goldsmith for having joined us from afar. And thank you very much.
Yes.
Dr. Owen.
Thank you very much, everybody. So that's the end of today. I think a pretty intense but excellent day. I was asked to give a summary of the day, so I only need about an hour, but it'll be fine. I think we'll still make dinner. So I do have a few points. Firstly, I'd like to sincerely thank the organizers. I think this is my first time at this meeting. It has been enlightening, educational, fabulous. I've learned a lot, so personally thank you, but I think on behalf of the clinicians, the healthcare people here, I think it has been very, very useful and important. I'd like to thank all of the speakers, the panelists in particular for their time and giving their opinions and for being honest and direct. I'd really like to thank the audience online and here. I imagine that seeing one's oncologist induces some somewhat negative emotions when you're coming to clinic and that, but I would like to share a secret that I think the clinicians here are also quite nervous about speaking in front of a room of parents. So I'd like to thank you for your insight, for sharing your stories, for your crucial questions, and I think we've definitely gone away with some homework. I wanted to just go through some of the themes. So we heard how important biology is, and we heard how important it is in terms of the tumor, but also the child. So the features of the child, that why did they respond and somebody else doesn't respond? Why did they develop a toxicity and somebody else doesn't? And those are all really important things that we need to learn. We heard a lot about toxicity and how we're giving more treatment. It's longer treatment. What's the cost of that? I think we're acknowledging that. We're not quite sure what to do about it because we're nervous about stopping or changing or replacing. But I think that's the next era of treatment. We heard how important collaboration is. So I hope you can see that transatlantic collaboration is very strong. It's vibrant. It's friendly, which is important because people can share ideas. People don't take offense when you don't disagree with somebody else. And I think we work really constructively. But I think we also heard that collaboration between healthcare and parents and advocates is really crucial. And Steve put it really nicely. I think he feels, I don't know, was it two men either side of him walking into the FDA, or it was stronger together. But it's the principle of advocates going in. You may not believe it, but we actually feel much more likely to succeed if we have that support. We heard about therapies and the challenges of developing new therapies, the challenge of improving current therapies. Where do we put the new therapies? Do we add? Do we replace? Can we make the current ones better? We had really excellent detail about small molecules, CAR T cells, ADCs, chemoimmunotherapy, radiobiology. So there's a vast field. We heard, how do we pick? How do we choose? But I think there are enough of us, and with advocates, we can definitely make the right decisions. And recently, or this last session, we heard about biomarkers and response. And so we have old biomarkers that are still very relevant, but we need to update them, we need to add to them. How do we do that? Changing practice is hard, but it's a huge priority. And it's a really challenging place to introduce new technologies or new techniques that change treatment. We definitely need your help to do that, because some people in the community, in the clinical community, would be very concerned and conservative about changing practice with the fear of making it worse. So we need your voice to help us make that decision, that we can be brave, we can change things, because we've got good reason to do that. We heard about equality and inequity, and amongst all of Meredith's slides, the one about the poverty index is really, really striking. We heard about challenges globally, and that's something that, you know, is a lot harder maybe to fix, but certainly something that we should and think about that. And lastly, I just wanted to reflect on something that Naomi and Mandy said, or it arose from a discussion. So we can do trials and we can have results that will impact on cohorts of patients, and they can help make societal level changes. So like national funding initiatives, or you need to fund dinutuximab beta. But we always have to consider the individual and the relevant unique patient features. I think you put it very well when you said that we need to make the best decisions at the time with the information that's available. And so we can consider all of the trials, but at the end of the day, it has to be a personal discussion. Hopefully there's a trust relationship between the clinicians and the family, that they can make that together in a productive way. And that's on us a lot of the time to make that work. So thank you for reminding us, and that was my message from the day, or the thing that I learned the most. So thank you very much. We hope, on behalf of the organisers, you found this very helpful. We hope to see you all back here again in the morning at 9 o'clock for a session on hope and survivorship. So thank you very much.